Hello everyone, my name is Rachel Moses and you are watching the HP Leader YouTube channel, and I'm delighted today to be hosting this session alongside some wonderful physiotherapists and specialist interest groups on what we know as dysfunctional breathing or breathing pattern disorder and everything that means in the context of long COVID. So this is a specialist podcast that's been in high demand. We've been asked by many different people to run this podcast, and I'm delighted to have the speakers today because they're experts in their fields. So without further ado, I'm going to ask everyone to introduce themselves, what their role is and where they're from, and then we'll go straight into some of the questions. So Cola, over to you, please. Oh, you've done it already. You're on mute.
Sorry about that. Thank you so much, Rachel. Thanks for inviting me. My name is Dr. Kola Akinlabi. I am a physiotherapist with respiratory specialism. My background is from intensive care respiratory physio, and then I moved on to chronic respiratory disease, leading from Whittington Hospital to now I'm in Barnet. So I am a COPD respiratory service lead, working with patients with COPD, long-term oxygen therapy, and pulmonary rehabilitation. I'm quite interested in long COVID, frailty, even NIV, and all sort of things that's done with respiratory. Lately, or recently, I've been appointed as the clinical lead for long COVID in Barnet, and I'm working with a lot of people, multidisciplinary team, looking at how we can manage long COVID in Barnet. Thank you.
So you are what I'd classically describe as the specialist generalist respiratory guru. So I'm delighted you're here today because you are specifically commissioned to run a long COVID clinic as well. And we're really going to value your advice on how to get this very important part of therapy included in long COVID services. So hopefully by the end of this, you'll hear exactly why. So Julie, coming down to you.
Hello, yes, my name's Julie Moore. I'm a respiratory physio, and thanks ever so much too for setting this up, Rachel. So I work with a company called Respiracare, who are commissioned to run post-COVID respiratory rehabilitation in the Bexley and Greenwich area. So for the last 3 months, we have been seeing a lot of patients post-COVID, and it's a program specifically around helping with people with breathing pattern disorders, which has been really interesting. But I also run a clinic up at the Institute of Sport, Exercise and Health, where I specialise in helping athletes with breathing pattern disorders, which is super interesting too. And I've been interested in helping people manage breathing pattern disorders for about 20 years or so. I'm a committee member of the BPD group, Breathing Pattern Disorder Group, and so it's a big passion of mine.
Thank you, and we're really grateful for your expertise, not only in the field, but also your experience with long COVID as well. So thank you so much, Julie. Louisa.
Hello, so my name is Louisa Stonehewer, and yes, I'd like to echo everybody else's thanks for inviting us to talk today. So like everybody else, my first love is pulmonary rehab. I've been working with all chronic respiratory conditions for even more than 20 years now, I feel. I am currently, my main job is pulmonary rehab for Coventry, but I've started working in the post-discharge clinics, COVID clinics, since October, initially just as a bank physio to give a little bit of cover, and somehow I've been nominated as the lead COVID physio for Coventry for my sins. So we are seeing mainly the patients who have been in hospital, but we are now starting to receive referrals from GPs with the ongoing COVID problems. And we are just about to start actually offering therapy over and above what I'm offering them as a one-off in the clinics.
Well, thank you so much. Really grateful for your time and expertise again. Now, Lizzie, over to you. And slight disclaimer, we work together at the moment. I always like to throw that in there. So Lizzie, over to you, please.
Yeah, hi everyone. Yeah, thanks for this opportunity. It's awesome to be getting this platform for breathing pattern and obviously long COVID as well. So I've worked at the Brompton for 15 years, which I'm immensely proud of. And within that role, I've kind of covered everything within adult respiratory lung disease. So anything chronic and anything grown up is my thing. But more recently, I've been particularly interested in kind of complex airway clearance as well as breathing pattern disorder in the context of asthma and unexplained breathlessness, which we have some great services that run through our centre. I suppose in terms of kind of COVID perspective, I was lucky enough to be working at the Hillingdon Hospital in their acute services for a period of time over the recent surge, which was fascinating and really awesome to work with their team. And so I had a bit of experience around that within the acute setting, but also I also do outpatient predominantly focused work more recently, including working for Air Physiotherapy, a private physiotherapy company. And within that, I've experienced much more, like other people have said already, around long COVID and how that interplays within breathing patterns. So yeah, thanks for inviting me today.
Definitely in a mixed bag. And I'm sure any of those that are watching that have looked up or heard anything about breathing pattern disorder, I'm sure they're all very aware of you three, so thank you so much. Paul, over to you last but not least, and our ACPRC champion as well on the podcast.
Thanks very much, Rachel, for inviting me. Yeah, my name is Paul McCallion. I'm a respiratory physiotherapist up in Newcastle upon Tyne Hospitals. I've been there for about 8 years now, with specialist interest in bronchiectasis and severe asthma, mainly focusing on airway clearance techniques and breathing pattern disorders. And from a COVID perspective, like I'm sure everyone else has, we've been on the kind of the front line for the majority of it. But now starting to see some people, particularly in clinics with backgrounds of bronchiectasis and asthma, come through post-COVID, and we are starting to see some breathing pattern abnormalities in these patient groups. So yeah, plenty of work for us out there.
Thank you so much, Paul, and thanks for joining us. And this will be on the ACPRC platform as well. So thanks to the ACPRC for that, and all the educational resources on there. So Lizzie, I'm going to come to you to deep dive into the $1 million question. So why does breathing pattern disorder exist? What is it? I want you in a few sentences to explain why this even exists.
Yeah, thanks. I mean, a few sentences is difficult for me, as many of you know, but I will try. So I suppose in order to understand what goes wrong with breathing, and I think, disclaimer, I'm going to call it BPD from now on. I know it's got a lot of terms and they're all important, but that's what I'll use from now on. We've got to remember what happens in normal breathing. Obviously, breathing charges hemoglobin with oxygen, it removes carbon dioxide, and it preserves the acid-base balance within our body. And it should be adaptive, appropriate, responsive, and the most efficient breathing for the condition that we're in, whether it be exercise or whatever. And there are precise mechanisms that regulate it, including obviously the ones that we know, biochemical and biomechanical systems. But we kind of also need to remember that there's other influences like stress, posture, cardiopulmonary interactions, emotions, and all those other things as well. And as physiotherapy colleagues in New Zealand describe, it's kind of the conductor of the orchestra. And can impact on all of our systems in our body. So what does BPD mean? Well, it often patients with BPD breathe in a manner that's sort of disconnected from those respiratory and metabolic requirements. Possibly their breathlessness is disproportionate. Often, although it can coexist with other conditions, obviously it can sit there on its own, and it's a complex interplay between, sorry about my cat's tail in the background, complex interplay between sort of biochemical problems, biomechanical problems, psychopathological problems, and cognitive factors. And it's thought to be prevalent in up to 10% of the population, going up to almost sort of 30% in asthma. And although we're unclear of its prevalence within long COVID, obviously, as we've talked already today, people are seeing it all of the time. So it's important also to say that BPD is readily misinterpreted, both by clinicians and patients themselves. And often those people are labelled with asthma or other diseases, etc. And that can be really quite destructive for the individual as well as the clinicians looking after them. And it can often amplify respiratory symptoms, which profoundly impacts on the overall health of patients. And often they're therefore less active and often quite a lot more depressed. So just to kind of finish, I suppose, in terms of COVID, a high proportion of our patients are still complaining of breathlessness, often in that kind of post-COVID acute illness stage, whether that be post-viral or whether it be in terms of long COVID. And some of these patients don't seem to have evidence of physiological problems. And so it's disproportionate to what we'd expect. And I think also what we're understanding even more is how that is interplaying with fatigue, symptoms of cough and kind of upper airway symptoms, autonomic dysfunction and sort of a mismatch or a lack of control within your nervous system also may interplay with the regulation and symptoms of breathlessness. So I think that kind of summarizes why it's important to recognize it, and it's particularly important to make sure that patients, where it's relevant, get access to the appropriate therapist to look after and support them in recovering.
Thank you very much. That was brilliant synopsis. Now, I just want to pick up on one thing that stood out to me that might stick out to some of our audience listeners. Up to 10% of the population, although the population's big, and 30% of asthma patients, is that right? Considering it's been like nearly 5 million people living with asthma in the UK alone. That's a canny few people, isn't it, that might have BPD on top of asthma. So again, trying to keep this in long COVID kind of thought, is there a link between severity of asthma, because we know there's a lot of mislabeling and diagnosis in asthma as well, like, or is there not? Is there no do we not think there's a correlation at all? What do you think, Lizzie? I mean, and then I'll move on to anyone else.
Yeah. I mean, you've got to remember as well, in terms of the prevalence data, it's data that's based on kind of, we know that breathing pattern is quite awkward to assess, and it's often a mixture of assessments that bring us to that conclusion. So quite a lot of that data is based on the Nijmegen questionnaire, which historically was developed to pick up hyperventilation. I think it's a really difficult question what you've said about, is it increased in severe asthma? Is it increased in certain kind of cohorts? Yes, we definitely know that there's characteristics of certain people. Female predominance is quite often something that comes up, but not exclusively. And I think it might be something that Louisa might touch on, but one of the things that we've talked about within the BPD group is how within COVID, it may be that the COVID kind of process is almost awakening something that was already a little bit sort of disproportionate, a bit like kind of posture. Some of us have bad posture, right? But it's only when we have an injury that perhaps that posture becomes have a deleterious effect on the symptoms that we're experiencing, perhaps with back pain, for example. Sorry, I'm not an MSK physio, so sorry if that is like out of vogue these days, but it could be that the COVID, if you like, is sort of triggering something in people that was perhaps already there, rather than it necessarily being a new thing. But I don't think we know enough about that in order to answer that clearly.
No, and we'll certainly see that in other things like ILO, like inducible laryngeal obstruction, other things. There's often other underlying things that something will then bring that out. So no, that makes total sense how you've answered that question, Lizzie. Thank you. Now, Louisa, I want to come into you for diagnostics and diagnosis, because this, again, just on the back of what Lizzie said in terms of potentially being multifactorial and potentially being underlying. And again, if we try and keep it in the context of normal and then COVID, do you want to just give us your experience of how we diagnose?
Yes, absolutely. And just following up on your question to Lizzie about the asthma, I was lucky enough to work in the severe asthma unit at Heartlands, and a lot of the patients that were referred in the difficult to manage asthmas had an underlying asthma, but had a very obvious dysfunctional breathing pattern. And by correcting that and dealing with the psychological side of that as well, we managed to take them from being difficult to control asthma back to asthma. So there is a big relationship between a dysfunctional breathing and other conditions. But when we look at assessing dysfunctional breathing, it is essential that we have a really good understanding of what normal breathing should be like. And so taking a very good subjective history is obviously the first part, and working out where the patients have come in with a respiratory problem. Most patients who are seen by respiratory physios will have a respiratory diagnosis, and it's working out whether the respiratory diagnosis is as a result of a breathing pattern disorder, or whether the breathing pattern disorder is as a result of the bronchiectasis or the asthma. So having a good understanding of what normal breathing is an essential part of being able to assess and treat breathing pattern disorders. So taking a good subjective history is vital. But when we look at the objective, I think it's quite simple, really. If you've got a good understanding of normal breathing, the first things that we will look at as a physio assessing would be their speech pattern. If they come at you speaking 100 to the dozen, etc., that's always a good indication that they've got something to get off their chest and a poor breathing pattern. Remembering that normal breathing should be in and out through the nose. We're all, quite a few of us have done the Bradcliffe, which is our colleagues over in New Zealand. Their mantra is nose, low, slow. So when we look at normal breathing, we're looking at making sure that we breathe in and out through the nose, limited movement at the top of the chest, and really engaging the diaphragm to breathe. So for a quick snapshot assessment of somebody's breathing is to look at those three elements: where the air is going and whether it's going into the bottom of the lungs, and then looking at the size and the rate of the breath as well. So the main diagnosis when we look at breathing pattern disorders is what the minute volume is compared to normal. So if they might be slightly bigger breaths but slower, or slightly faster but little, the minute volume stays the same. So there are lots of different assessment tools, and we haven't really got time to go into them all. The Nijmegen questionnaire, as Liz has already mentioned, is one of our original forms, and that is looking more for hyperventilation. So hyperventilation is a part of breathing pattern disorders. It's not it all. And that's looking, if you're breathing too fast, you're likely to lower your carbon dioxide. If you lower your carbon dioxide, you're likely to get one of a few different symptoms, and that's where the Nijmegen comes in. My favorite quick test is the breath hold. Again, we won't go into the technicalities of it, but if a patient can't hold their breath for 10 seconds, then their inhalers won't work. So it's always a good, simple test to do. Just ask somebody to take a breath in and hold it. And the other one that is being used quite a lot is the BPAT, or the Brompton Pattern Assessment Tool. Is that right, Lizzie? Which is a quick tool to assess what somebody's doing within a minute. And I think the BPAT is a very useful tool, and I think it's a good focus, particularly for non-physios, to use that as a focus, to just focus on having a look at the actual breathing underneath everything that the patient is telling us. So I think it's a handy tool to be using particularly in the COVID clinics. So one of the questions that we ask all our patients is, are you breathing in and out through your nose or your mouth? And one of the answers we get is, I've never been able to breathe through my nose. I've always breathed through my mouth. So I think when we look at our COVID population, regardless of what their conditions were before, and I like Lizzie's analogy of the back pain, and it's one I use a lot, is that you can carry along having a bad posture for a long time, and then you might just bend over and pick up a piece of paper and your back goes, as people say. And with the COVID, they may well have carried on with a dysfunctional breathing pattern for a long time. And all sorts of things influence our breathing, injury, pregnancy, all sorts of things. But we manage, and then we have a final insult to our body, both the stress of COVID and the physical stress of COVID, that then triggers a massive response. And so we're then trying to get them back to their baseline. So, and I mean, what has been interesting, and I'll see what the other people feel, is that actually, because the shielding has worked so well, that our respiratory patients, very few of them actually ended up in hospital with COVID, because they were shielding them so well that they didn't catch it. So it has been interesting that we haven't seen many patients with underlying respiratory conditions in our COVID clinic, at least.
That's absolutely fascinating. I mean, the speed of talk, like how fast someone talks. I'm just thinking of some of the patients that I've seen there, and you're absolutely right. I've just never conceptualized that before with breathing pattern disorder, and that's terrible as well. But I just never have.
One of the treatments is to teach them how to control their diaphragm and their speech. And one of the techniques that we use is to put commas in your speech, but you're also putting commas in your life. So one of the big problems that we're finding with all our breathing pattern disorder patients, and again with the post-COVIDs, is that if people tell them that they're breathing badly, or if people tell them that they're hyperventilation to the general public means panic or anxiety. And anxiety means it's something in your head. And so if these patients come in with a symptom and they hear that it's just in their head, that sets them off. So learning to calm down your breathing and calm down your speech is a real one of the first treatment aims with a breathing pattern disorder, is to, as I say, to put commas in your life, put commas in your speech. But you will know the patients who sit on the edge of the chair with their shoulders up, just as we are all eager to tell you. And I certainly had a chap come into my COVID clinic the other day who literally shouted at me for 10 minutes. Not aggressively, he just had so much to get off his chest. Literally, physically, he was fixed up at the top, and vocally just talk. So
it's absolutely fascinating how this is so different, and like you said, is a speciality within itself, because I think it's like my background, neuromuscular disease, chronic, maybe this is Cola where you're coming in a little bit, in terms of like chronic lung diseases. You start by explaining the pathophysiology of why they're breathlessness. You reinforce them that there's a reason they're breathless, and then you work back from there. But with this, it's actually like, there might not be a physiological cause why you're breathlessness. It's because of the way you're breathing or other factors that come in. So it's almost like turning some of the chronic disease management on its head a little bit, like you're saying. But the assessment is the key. That's what you're saying, Louisa. It's about, and by someone who has the specialist skills to be able to pick maybe some of these subtle cues up as well. So, and you've just fed nicely into Julie there in terms of how do we actually treat this? So I know this is beyond the concept of this podcast in an hour or 45 minutes, but do you want to talk to us, give us a flavour of what you guys do?
Yeah, sure. So a big part of this is going to be education, isn't it? Is helping the person to understand how they breathe, and reassurance. Some of these patients have got some really weird symptoms, and they've been passed from clinician to clinician, being told that, there's nothing wrong with them. And that's, really hard for them. So for initially, you might be the first person that actually give them a really good reason why they're feeling what they're feeling, which is very powerful, because then you can then go on to say, right, now let's have a look at how you're breathing. So there's a lot of education about helping them recognize and self-assess and be self-aware of what they're breathing. And often, the breathing pattern can be very subtly altered. They're not always that obvious. So, it's not until you sort of make someone realize the importance of whether they're breathing through their nose or their mouth, and explaining to them why the nose is so much more important in terms of what it does and how it cleans the air and moistens the air and, enables you to use your muscles properly. It's really powerful, the educational part. And then obviously, once you've helped the person sort of identify how they are breathing, and there'll be the different components. Are they breathing through their nose and their mouth? What muscles are they using to breathe? How fast are they breathing? What the volumes are? So you've got quite a lot to work through there. And so you've got options of either going, right, do we go just with one component of that? Because actually getting someone to close their mouth can be really challenging, and that might be all you focus on initially. Or it may be that you make this super easy, and you get the person lying down comfortable, pillows under their hair, pillows under their knees, and you literally try and switch off all the muscles as much as possible, and you enable them to start to feel their diaphragm breathe and enable them to feel where breathing should be. And often they go, oh wow, that feels really nice, or that feels really different, or you get different responses. So your goal essentially is to enable the person to normalize their breathing, as we've been saying, trying to basically get them to breathe through their nose with their diaphragm, a good, nice, relaxed rate with good volumes. And so you're going to work through that. The problem we've got, that in itself is potentially easy. The problem we've got is life. So many triggers make people breathe very badly. So your assessment, that, as Louisa says, that subjective assessment is absolutely crucial. And as a clinician, I'm always, as they're telling me their story, I'm thinking, oh, that's going to make it worse. Oh, that's going to make it worse. And so in my treatment plan, I'll be thinking, okay, whether they're a teacher and they talk all day, or they've been mouth breathing for, long periods of time because they've got some nasal issues, you're going to have to go, well, we might have to treat those nasal issues. So you've got to look at the triggers that might be stopping that person from getting their breathing pattern to normalize. I think it's really important to remember, there's a huge sensory component to breathing. And sometimes even just talking about breathing can make someone want to breathe more. And often we're trying to get people to breathe less. So you have to be careful with that you don't push the person too fast, too quickly. You know, it could be quite a methodical process where they might have to just do a minute of good breathing at a time, and then they slowly bring that up. And often you may have to come at a completely different angle. So sometimes people don't respond very well to that real focused breathing with training, because it makes them breathe faster and deeper. And it's like, well, okay, this is not what we want. So then you have to think about, okay, so how can I help this person to breathe less, breathe normally, breathe well? And relaxation is, you know, is a huge part of our treatment. So getting the person to understand their tension levels, trying different relaxation techniques. And in actual fact, if you get the person relaxed, the chances are they'll start to breathe well, breathe more optimally to what they're doing. So there's a lot of work you can do. And I probably should just add in as well as, you know, we sort of always talk about normalizing breathing at rest, but we've then got to get the person to be able to move around and function and maybe do their exercise as well. So it's, although it tends to, if you fix the person's breathing pattern at rest, it will possibly start to, because you're aiming to try and get the person to breathe within their metabolic requirements. Once someone starts exercising, that can be quite challenging. So you have to really work on that person in terms of really making sure when they're moving around that they're biomechanically working, using the diaphragm properly. Not that we often see that upper chest gasping, don't we? So it's really trying to get that lower nice rib cage movement. And using the nose, you know, to help control the breathing much more. So, you know, there's a lot to do, and I could probably go on for even more, but I won't.
No, that's absolutely fascinating. And there will be some people listening thinking after what you've just said, oh, like, so it's in someone's head then, because we'll have to retrain the thought. But if we're linking it to long COVID as well, and particularly not just COVID, but anyone that recovers from a significant viral illness, we know that fatigue plays a massive part in it as well. And because people are fatigued, that automatic compensatory technique is to breathe more, even though they don't necessarily maybe need more oxygen, or they don't need to have a high respiratory drive. That's a compensatory technique. And we see that in like the post-intensive care population of patients. Now, breathlessness post-COVID is definitely complex and we don't know the answers. It's linked to high viral load. It's linked to infection. We're going to concentrate more on kind of patients who weren't hospitalized and who have this long COVID phenomenon, who maybe had a very mild illness, who then have this kind of episodic breakouts or potentially a significant episode 3-6 months down the line where they've completely crashed and burned. And then they describe this ongoing breathlessness. Now, from what all of you have said, is that might not be breathing pattern disorder, and there might be an element of breathlessness, and then might be an element of post-exertional malaise, and then there might be an element of fatigue. So what we're not going to try and do is explain and account for all of that in this session. But what we really want, and this is where I want to bring a new caller, then I'll come back to you, Julie and Paul, is what are, in everyone's experience in long COVID clinics is so different, but we're seeing trends and we're seeing some kind of similarities. So caller, just from your perspective on listening to the last three speakers, what are you seeing in your clinics? Are you seeing this phenomenon? How, you know, what advice are you giving? How is it presenting, etc.?
Thank you so much. Yeah, I mean, what we are seeing in long COVID clinic, you see arrays of symptoms, you know, clusters of symptoms. Some of them you can't put your fingers on them. I mean, if you check NICE guidelines, quite a lot of elaborate symptoms across, you know, most systems. And, you know, I'm quite surprised with most of the evidence that you read or literatures, even in long COVID, that, you know, breathing pattern disorder is quite, you know, very quiet in terms of reviews and things that we've seen. I know that breathlessness seems to be, and fatigue seems to be the biggest of all, and, you know, cough sometimes. But I think underpinning the breathlessness is the, you know, breathing pattern disorder. And some people have actually argued, even in some of the literatures, whether actually breathing pattern disorder and breathlessness is what is causing the fatigue. I know there have been a lot of evidence around the pathology of fatigue in the brain. You know, you have cerebral acidosis causing fatigue, and downplaying it peripherally and causing, post-exertional malaise and all that. There's been a lot of evidence around that, but there are some evidence also around the fact that people that experience breathlessness, probably they have VQ mismatch around, the fact that you have less perfusion to diaphragm and you're having diaphragmatic, muscular dysfunction. I mean, also around patients who are long-term ventilator, ARDS type, or, they've been deconditioned because of their ITU stay. So there are so many issues around breathing pattern disorder or breathlessness that we don't know what is actually happening. I mean, if you think about it, most of you would know, you have microvascular defect in long COVID. A lot of people have suggested that that might be one of the reasons why the diaphragm is not up to maximum capacity. You have less perfusion. And then, if you all remember as respiratory physio, the volume pressure curve, you're having problems around middle ventilation. The middle ventilation is a little bit low because the diaphragm is not up to maximum, capacity. And you haven't got enough volume. So patients tend to change their breathing pattern because of all this defect. And before you know it, the behavior will kick in. The system in itself, peripherally or centrally, is making a lot of changes in terms of how people breathe. So there are lots of, suggestive pathology that we don't yet understand that we think might be causing breathing pattern disorder or might be causing breathlessness. I would say, from my experience in clinic, we see, I would say, about 80% to 90% of patients with breathing pattern disorder. I mean, literally, you call them to clinic, you see them, they're mouth breather, the respiratory rate is a lot, and they can't control to close their mouth while they are breathing. Even when you're teaching them retraining, they can't accept it, and I'm thinking, perhaps this is not something that they've just put up or behaviors. It might not be something that have been there before. It could have been there, or this is all new because of diaphragmatic dysfunction. I mean, what I see also in clinic, you see most of them, a lot of them will have exercise-induced desaturation. Once you do 6-minute walk test, within the 6 minutes, you see them desaturating, but good enough, most of them pick up within 1 minute after the test is done. So we don't offer them, ambulatory oxygen. But it's quite interesting to see how this patient plays in terms of clinical symptoms and features. So you see all sort of different assessment defect within this patient group, and you can't quite understand why you think this patient might be having this problem. Some of them, when you think about it, their 6-minute walk test could be less than 130, which is quite a significant problem in terms of prognosis for that kind of patient. And we're seeing quite a lot of them are young age kind of people, between 25 to 38. Max I've seen is about 42. And if the patient is obese, it's quite a big problem as well, because already the diaphragm is split already and they are having hyperventilation. The diaphragm is not up to full capacity of pressure or activity. And then they have breathing pattern disorder, or they've been admitted into hospital and they've developed this problem. So you see them displaying quite a massive amount of symptoms around, breathlessness, breathing pattern disorder, and all sort of things that you can link with it. I think that we need to do a little bit of more work, because, I mean, we are collecting data as we speak in our center to understand, the cohort of patients that we are seeing in clinics, whether or not there is a problem around fatigue that's causing breathing pattern, or even if it's lung function defect, or even if it's just breathlessness in itself, or is it exercise-induced, hypoxemia that's causing this? I remember in some literatures in the SARS-CoV-1 down in 2002 in China, they did some sort of investigation on patients about 8 weeks after they did their lung function, and they found that about 60% of them have lung function defect around, restrictive lung pattern and also reduced lung function capacity. And that is telling you about whether or not they have, fibrosis or some chronic respiratory disease that's causing, breathing pattern disorder, or why they're having restrictive pattern disorder and breathlessness. And most of these patients, they continue to have this problem over 12 months. So we are seeing all sort of patients in our long COVID clinic that, we don't well understand why they develop what they develop, but there have been a lot of suggestion around different pathology that could be causing this problem.
Definitely. And I think the thing for me about long COVID for those patients that haven't had a hospital admission is normally it's linked to severity of the viral illness. And normally we'll see that linked to viral load and the after effects of that. But this phenomenon, there's no real correlation in that. This is the thing I think that people are finding most challenging. And Julie, I'm going to come to you after Paul, because I want you to try and answer some of Cola's hypothetical points he's just put out there, but also what a lot of people were reaching out to me about was this concept unexplained breathlessness. Now we know we have unexplained breathlessness clinics. Some clinics call themselves that, and then to find out why they're breathless. Sometimes that's breathing pattern disorder or problems with their larynx or breathing muscles. But this is this phenomenon now. Cola's incidence prevalence is really, really high there. I don't know if you other guys have heard of that's quite common, but that has shocked me. Paul, do you want to come in with any comments of what you guys are seeing in the Northeast, and then Julie coming to you, and then Louisa, and then Lizzie as well for comments on that?
Yeah, so I've already covered a couple of the long COVID clinics. Fortunately, one of my other colleagues are doing at the minute. But what I am seeing, I suppose, from the clinics, from the bronchiectasis patients and asthma patients, I'm actually seeing quite a number of, like a surprisingly higher number than what I thought, who have had COVID, not hospitalized, and I'm now actually finding during kind of almost routine follow-up assessments that they've developed in this, obviously they're more breathless than what they have been, in the past assessments. And it's difficult to put down, is it the fact that they have been shielded and they're deconditioned, where normally you might say to those patients, let's consider pulmonary rehabilitation, and you would go through those normal kind of potential options to improve their fitness and breathlessness. But when obviously you then throw in the spanner in the works, I've had COVID, I wasn't hospitalized, and you need to obviously consider, well, is there other potential other options to explain your breathlessness? And out of the ones that I've seen, I mean, I would probably say we've got probably about 600 patients here in the Northeast with bronchiectasis, of which I'm probably hitting double figures now, where I've kind of seen breathing pattern disorders on routine follow-ups for non-hospitalized patients. Now, obviously, that's, we're not quite obviously a year into it now where I'm doing my follow-ups, but it is quite kind of an interesting amount. And this is something that I didn't necessarily expect, the fact that, all these patients were strictly shielding as well. So maybe that, I don't know if that's a Northeast thing that we're seeing these numbers, or if these type of things are going to start happening kind of throughout. But it's definitely something I think from a specialty point of view that we need to be taken into consideration whenever we are doing these kind of follow-ups. Don't assume that it is just the bronchiectasis or even their asthma. Consider obviously COVID, and that there's this potential new interaction of symptoms that we don't quite know yet.
Thank you. Now I want to move on to the commission and the clinic side of it in a little bit, but just to put you three on the spot about some of the things that's brought up there, and also nutrition, because when nutrition has a big impact on unexplained breathlessness as a concept, and deconditioning and fatigue, and we absolutely underestimate the massive impact in the acute phase of the ITU phase on the respiratory wards and nutritional impact of COVID. But I don't think we've necessarily maybe thought about the nutritional impact on non-hospitalized patients, if there is any at all. But I know that dietitians are an absolutely essential part of having referrals onto dietetic services in the long COVID clinics for that reason, if people are nutritionally optimized. So that's something else I'd like one of you to touch on. But Julie, coming down to you in terms of what we're seeing in clinics, what we're seeing in these patients, is there any type of phenotype? Is there any type of red flags other than what you've mentioned? And just people listening to this who are either involved in long COVID clinics or who might be seeing these patients in the community, what kind of things can they be looking out for?
Yeah, so I think just to reinforce what Kola was saying about the numbers that you found, we have screened, it's about 75 patients so far. We looked at their breathing pattern assessment tool score, and 93% of them scored significantly. So that's 4 or more. So big chunk, similar to you, wasn't it? You said 90%. We also did the 9 Megan, so 66% of them were actually hyperventilating as well, if we look at that as a potential screening tool for hyperventilation. We had, what was it, 50% were deemed anxious from the GAD-7 and 62% depressed from the PHQ-9. So lots of overlay between psychological profiling and their sort of physical breathing pattern, and obviously symptoms of fatigue, breathlessness. Not sleeping. Sleep was a big problem for these patients. So if they're not sleeping, they're not recovering, they're not able to re-energize, and it all just gets very complicated. And often the patients that I saw were back from wave 1, and so they've been left for like 10 months or so on their, pretty much, because like you say, they're not patients that were admitted, they looked after themselves at home. They've been screened, they've been told there's nothing wrong with their lungs, but they're still struggling with the breathlessness. They keep, the profile of these people are young, as we said before, 20s, 30s, 40s, previously fit, so they want to try and get back to their previous COVID levels, but they often try too hard, too quickly, too soon. And you can imagine if the breathing's not right, and then they get one good day and they think, oh great, we can go ahead and do this, and then they can't, and they get stuck in that boom bust and they come crashing back down again. And often we sort of come along, we've had to sort of pick them up and go, right, okay, let's just slow down here. Let's just sort the breathing out, get you sleeping right, get you eating right, get you hydration. It's a real lifestyle thing that can help these patients, put them back on the right road to recovery. And the work that we've been doing an 8-week program, and I've had the pleasure of working with Natalie Hilliard, who's a physio for ME. And so it's been fascinating. Our worlds have clashed. They've collided. I would say clashed, they've collided, but like super positively, where we've come together and run a program where we realized the work we do overlaps so much. So it's been super interesting to see that unfold.
I'm glad you mentioned that, because this podcast is going to be linked to the long COVID update we're running, and I'm hoping to get you guys together on one of the sessions for that exact reason, for the overlap. So thank you. Now, Kola, I can see you wanting to come in then. I'm coming into Louisa and Lizzie next. Kola.
Yeah, very quickly. Those patients, non-hospitalized one that continue to experience breathlessness and then coming up with, a problem with breathing pattern disorder. I think one of the things that we are thinking that is going on is because most of these patients, or even most COVID patients, their main problem acutely is hypoxia. And we know that the more hypoxic you are, the more you're more likely to, to die. The mortality rate is quite high, in around 92 to less than that, than those who have 94 to 95% of oxygen saturation. So if they have been sitting at home and they've been hypoxic and suddenly they got better and then they have microvascular defect, they're going to be a little bit hypoxic or even more, and the diaphragm is not going to work as much, and then they might end up having breathing pattern disorder, breathlessness ongoing, all sort of things ongoing. I mean, I was reading a literature 2 days ago, and one of the reasons what was written in that literature was around the fact that the reasons why we're having long COVID is because most of these patients have been sitting at home without any care and they've been hypoxic. I thought I should throw that in, whatever that means.
It's very true, and I think that's a point. We just don't know, and I think sometimes we hypothesize that we know, or we almost predict, or we try and second guess some of the symptoms and the causes. But I think what you've all beautifully described is sometimes just look at what you see in front of you, and the cues that you might see might be very different through my eyes because I haven't got your background. So again, this is kind of going to bring us into the next question, which is around the specifics around the clinics and who do you need in there, and what do you need to look out for. But Louisa, first of all, can I come to you to see if you've got anything to add into that in terms of what we're seeing, what can we look out for?
Well, I think what we're seeing in our clinic is that there doesn't seem to be a lot of physiological damage or changes to the lungs. And I think we have to be very careful about over medicalizing the effects of, if we're going to call it long COVID, and I think post COVID is a better description really. If we over medicalize it and try to find too many reasons for it, that we're then not moving forwards. So this is my biggest concern, that we are seeing patients with near normal CT scans, near normal X-ray, near normal spirometry, and all of our patients are having spirometry, but with a dysfunctional breathing pattern. And we will never know which comes first, the chicken or the egg, whether it was partly the dysfunctional breathing that has led them to having more COVID symptoms post, or whether it's the COVID that's led to them having more dysfunctional breathing. We'll never know. We've got a huge big group of people here to look at. There's definite divisions between the people who were in hospital and the people who weren't. So I think we just need to be a little bit careful on over, as I say, over medicalizing it and making assumptions. And we do know that if people have a dysfunctional breathing pattern, that is going to then can have an effect on their fatigue. And yes, I understand that the fatigue can have an effect on their dysfunctional breathing. I think the other cohort that I'm most interested in is when we are managing them in hospital with high flow oxygen, with proning, with CPAP, and even just simple things like sticking an NG tube up somebody's nose will make it difficult for them to breathe through their nose. But if we're hyperinflating these patients, necessarily due to the nature of the COVID, is that we're not correcting that post. We're leaving them with a hyper-expanded chest and a hyperinflated chest, where their stretch receptors have been on full stretch for 3 weeks or so while they've been on CPAP, and that we're not bringing the stretch back down. So I think and even I think with our patients who've been at home, where they have had to breathe fast, hyperventilate. It's not hyperventilation because they're not breathing in excess of their needs. They've had to work hard to breathe, and that habit has been triggered, and they're continuing to breathe with that. So I think that's where my focus is bringing their breathing back to normal as much as we can. And is the diaphragm weak because they've never really used it, or is the diaphragm weak due to some COVID related damage? Again, we will never know the answer, but we do know in our non-COVID breathing pattern disorder patients that they all exhibit a weak diaphragm due to lack of use. So it's just another thing to be aware of, really.
Absolutely. And high flow is fascinating for many reasons, as you say, but also it's just not physiologically normal through the upper airway to get that much flow. And yes, the concept reduces respiratory drive and effort, but there is also a counter effect of that in terms of the reaction within the airways. And I certainly agree with you. There's a lot around that therapy we don't know, and we've never used it en masse, I don't think, within a population of patients like this, like we have in this pandemic. And Lizzie, that's a nice time to bring you in terms of, there'll be some listeners out there as well that are thinking about what can we look out for more acute. So Louisa's just very nicely if we could come over to you in terms of ask you, actually, I don't know if Lizzie's frozen. Are you there, Lizzie? I think she's frozen. So we might come back to that question if Lizzie comes back to us. But Julie, can I come back down to you just to kick us off for one of the final questions around, if we have people that are listening who are either running long COVID clinics or setting up long COVID clinics, or who are looking to for advice. And I think, my God, I've just never even thought of this before. What advice do you have for people, who want to pay more attention to breathing pattern?
Oh, I think Lizzie's back there. I'll kick off and then Lizzie can join in. Are you back, Lizzie? Oh, so just talking about setting up clinics and what we can advise people. I'm a massive fan of the BPAT tool. I feel like if we're trying to help educate people that perhaps don't have the knowledge and experience of identifying breathing pattern problems. It's a tool that takes a minute to look at someone. It's easily scored, and it obviously it's in its own right. You know, you have to be careful. You have to use it with what you're talking to patients. But you know, as physiotherapists, as clinicians, we're going to assess the patient. But it really helps you to understand whether the person's breathing optimally or not. Generally, I think in terms of setting up clinics, as we probably all agree, it's got to be multi-professional. You know, breathing is so influenced by mood, and so, you know, we've had very great connections with our local IAP service, and they've been brilliant at joining us on our program and making people become more aware of their mood and recognizing the symptoms of anxiety and depression. Because often when you have a breathing pattern, you know, it can be driven from those sort of psychological drivers. And sometimes I worry that, you know, we can really go to town and trying to get that person to correct their breathing. But if you don't get to the root of the problem, then, you know, you may find that you don't get the response of the breathing pattern changing because you haven't addressed the under the psychological issues that the patient needs. So that would be the advice I would give.
Thank you so much. Now, Lizzie, I was going to come into you to talk about what we should be maybe more mindful of. Maybe being in the acute centre, I don't know how far you listened to Louisa's talk, but you bridged really nicely into the effects of high flow therapy, prone positioning. Obviously, we know the effects of mechanical ventilation on breathing because of the reverse pattern, but what maybe should we be looking out for?
Yeah, so sorry if it's clunky because I don't know what happened. I was lost for a while. But anyway, I think it's really interesting and picking up on particularly what Louisa was saying around how she's particularly kind of thoughtful of how we need to be thinking about it differently in perhaps post-acutely, and also then in this kind of longer post-COVID type cohort, which I think Julie's described really nicely. And I think it sells two things to me. The first is that all physios should be considering breathing pattern in their assessments. Let's not make it something special. Yes, it is a diagnosis of which there is a group of things that a patient may present with, but also it should be fundamental to everyone's assessment, just by the same token that breathlessness is. And I think Paul mentioned it as well with his kind of chronic patients. Everyone could benefit from breathing better, and how you then adapt that and kind of access that with the patient will depend on their story. So yes, the patients that are acute, that have gone through that terrible trauma, whether it be through high flow, CPAP, you know, all the other things that come with that, I'm not saying that you would treat them in the same way, but certainly to interplay your breathing pattern assessment across the board is just essential. And it's one of the things that I am passionate about us doing. Let's not make it different and special and kind of awkward, because yes, there is the patients that are complicated that Julie talks about, the ones with psychological difficulties, the ones that maybe this interplay with fatigue and dysautonomia, which I can never say. Yes, they are the complicated ones, which you may need support with, but every kind of respiratory physio, you know, band 5 upwards should be able to kind of assess someone's breathing pattern. And I think to bring that in as well, and this may link into a question that you'll come up with later, Rachel, about what we do going forward, but I think respiratory consultants and cardiology consultants are aware that these patients are going to arrive in their clinics. Yes, they may arrive in long COVID clinics, but they may arrive in clinics where people don't really know what's wrong with them, you know, what their symptoms are to do with, which is exactly what we see in breathing pattern at the moment within the asthma cohort. They can take up to 7 years to get a kind of firm diagnosis that's right. And so we're going to see these patients in clinic. So I think it's really important that we do get that physiological assessment to know that there's no end organ damage, like Kola was saying, that you know, he's obviously seeing a lot of in his clinic. So it is important that we get that, but at the same time, we can work in parallel with the symptoms that the patient's presenting with. And I think the final thing that I would say that I don't know if it links to the question you originally had, but patients with this breathlessness, whether it be acutely or whether it be in these kind of longer COVID clinics, they often feel unheard. They're often really frustrated. Like Julie said, that often they're quite young and fit and it's kind of come from nowhere. and they feel disbelieved, and that's known in our kind of the evidence that's out there from GPs around COVID patients. That's known that they feel disbelieved. So it's really important that we're empathetic to patient symptoms and that they feel validated. And validation of symptoms is something that we've been doing with BPD for such a long time. The therapeutic connection that often we get within physio is really powerful. And that's not to say it can't happen with other MDT members. It absolutely can. But I think we have such a unique opportunity within our assessments to really kind of do a problem-based approach, and that's often where that validation is so important for that patient to feel empowered.
Thank you so much. Now, I'm really keen to finish on time, so I'm going to give you each a second to think about the final remarks, because I always like everyone else to finish. So a final point we maybe haven't have covered, or just a conclusion from each of you. Paul, I want to come into you first to signpost us to the resources that are out there for people who want to know more.
Yeah, so I mean, obviously we've got several members of the group here, but the fantastic website, Physiotherapy for Breathing Pattern Disorders, you know, I'm not a member myself, so I can pitch it. It is a fantastic website, and it's got a fantastic both paper and video resources as well, and audio. From an ACPRC point of view as well, we do have on our website some breathlessness management, both for the patient, but also for carers of patients as well. So yeah, so there are kind of really good resources out there, and yeah, please take a look. And for anyone who is listening, just drop me an email. My email's on the website, and please, I'll try and help you as best I can.
And if they want any more follow-up podcasts or anything, I'm sure they can let you know, Paul, through the website.
Absolutely.
Julie, I'm going to come to you first in case you need to drop out. You're a woman in demand, so over to you for final thoughts.
Yeah, I think, you know what my advice would be is don't overcomplicate this. Anyone that's helping someone with whatever the person is there sitting in front of them, what they're telling you might sound really complicated and all these different symptoms, but normal breathing isn't complicated. And just come back to that, you know, you're aiming to normalize their breathing. So just remember that when you're thinking, oh my gosh, they're saying this, they're saying this, they're saying this, normalize breathing pattern.
Thank you, and thanks so much for your time, Julie, as well, in case we don't see you at the end. Cola, coming to you next.
Yes, I'm just going to say that if you're looking for help in commissioning your long COVID, we have drafted a SOP that will help and then try and speak to your GP who is interested in respiratory in your borough or within your CCG. We were very lucky to have the North Central London, CCG helping us, because in Barnet we have one of the highest prevalence of COVID, and that's helped us to put it out there to the CCG. We had to, let them know about demand and capacity that's required. And then the fact that we have a lot of long COVID patients sitting at home. So yeah, so you can reach out to me. We've got a SOP, we've got something, we've got a process map, even the MDT, how to run it and all that. So you can always reach out to me through Rachel or myself directly. Thank you.
Yes, and you are going to feature on a lot of these things, Cola, for that reason. So thank you so much. You're my go-to long COVID clinic chap. Lizzie.
I think sell yourself, sell what skills you've got, whether that be as part of an MDT or if you do fly solo. Try to make sure that you get connections with your MDT members, because it is key to sell yourself and educate, and kind of what Julie said, really, don't overcomplicate it. Let's just get the patient mileage, practice your breathing pattern assessments, and I promise they get simpler and easier the more that you do it.
Thank you, Lizzie. Louisa.
Yeah, I think following on from both Julie and Lizzie, my go-to answer is you can't do anybody any harm if you teach them how to breathe properly. So no matter what's going on underneath, if they learn how to breathe properly, you're not going to make any condition any worse. So have the confidence to assess and just give them a something to help them improve. And yeah, thank you, Paul. Have a look at our website, and we've got the nice videos on there. So that would be my go-to. You can't do any harm by teaching somebody to breathe better.
Love that, Louisa. Paul, final words.
Yeah, just to kind of summarize what everyone else has been saying, keep it simple. You know, obviously a lot of the talk's been long COVID, and rightly so, but even from the normal patients, the patients with chronic conditions like bronchiectasis, asthma, COPD that you will normally see if they've had COVID, keep it simple. And yeah, as Louisa said, you can't do much wrong if you teach them how to breathe.
Thank you. And a massive thanks to everyone on the panel today. There are Twitter handles on the YouTube and the Podbean information, but please reach out if you want to get in touch with anyone. They are more than willing. Thank you so much, everyone.